case 是一个 pleural effusion. So the first case is a pleural effusion from an 81-year-old male. So I think this is quite easy for everyone now because we've seen these more and more these days. So you can see majority of the cell have these eccentric nucleus with intracytoplasmic material stand a little bit like orange or like a light brown color, suggesting that it is mucin. So majority of these cell looks like a signaling cell. And you can see scattered cells will show prominent nuclei and definite nuclear atypia, but majority of the cell looks quite bland looking. So this is the feature of signaling cell carcinoma. The specimen is from pleural effusion, but the patient actually had a gastric cancer with signaling cell morphology, the history of gastric cancer. So it is a metastasis from the stomach to above diaphragm to the peritoneal cavity, to the pleural cavity. So this is very typical for gastric cancer with metastasis. So if you take a look of cell block, you can also see this is very typical for signaling cells. And this is loose stent. The cytospin preparation doesn't perform well, but you can still appreciate there are some material inside the cytoplasm. So this is metastatic gastric cancer. The second case is actually a new patient. He's 67-year-old. This is also pleural effusion. So in this specimen, in the background, you can see there are more prominent inflammatory cells, mainly lymphocytes. But you can appreciate scattered cells, some with like single cells, some with a small cluster, but all of them show very prominent nucleoli. So you can see this is a cell with binucleation, and this nucleoli is really prominent. Here, prominent nucleoli in a cluster, and the cell morphology show marked variation in size and shape. So this is polymorphism. And here is also, and here this is also a very prominent nucleoli, almost as big as the adjacent lymphocytes. So this is adenocarcinoma. And in the background, we show it shows prominent inflammation. The tumor cell is actually not so many. So if we take a look of the cell block preparation, so here we see some fibrin, and here we see one cluster of cell with like artificial cleaving around the cell cluster. So this is very typical for a metastatic adenocarcinoma. In the cell block preparation, it will show these artificial like spaces around the cell cluster. So we will do a TTF1 because this is a new patient. This is his very first diagnostic specimen in our hospital. So here again, you can see it's also very typical for adenocarcinoma. So we will do a TTF1 for this case. The third case, he had a prior history of primary lung cancer with EGFR mutation. So the specimen is from pleural effusion, and we want to check if there's any tumor recurrence. So in this case, the background is pretty similar, also show a lot of inflammatory cells. But from area to area, you will see these pleomorphic cell cluster, and the cell is markedly enlarged. The nucleus is markedly enlarged, and there's a triangle like a nucleoli, looks very suspicious. And from the same cluster, you can see this variation in size of the nucleus. So this is adenocarcinoma, and this is positive for recurrence adenocarcinoma. So the morphology is very similar to the prior case, which is a new case, but this is a recurrence case. So the next specimen is a touch imprint from a lung needle biopsy, CT-guided lung needle biopsy. So in this type of specimen, usually we don't have a lot of cells. So now we are pretty familiar with the morphology of primary lung adenocarcinoma. But this specimen looks a little bit unusual. First, you can appreciate there are some extracellular material, looks very oranginophilic. So this is mucin. So in the primary lung cancer, rarely there would be mucinous adenocarcinoma. It's less than 10%, maybe 5% or even less. And here you also see there are some necrotic debris in the background. So the combination of mucinous material, necrosis debris, and we also see positive malignant cells over here. So this is compatible with the patient's past history of primary colon cancer with metastasis to the lung. So this is the metastatic colon cancer in the lung. So the colon cancer frequently will present with the mucin and the necrotic debris. For the cellular morphology, sometimes it will show more prominent stratification, like an intestinal type epithelium, but here it's not easy to appreciate. But because of the background material and the prominent necrotic debris, this is compatible with metastatic colon cancer. So this is also a typical cytomorphologic correlation. So finally, we have a case which is pap smear. The patient actually had a prior history of high CO, and I think she received biopsy at the other hospital and came to our hospital for second opinion. So we do a pap smear at first. It was signed out as negative. And the patient subsequently received colposcopy biopsy, which is also negative. Then she received a cone excision, which show high CO. So in this scenario, this is a 46-year-old female. So you can see the pap smear show very clean background, and the ratio of superficial cell is more than the intermediate cell, suggests that she is a relatively young female, so which is compatible with her age. In this specimen, indeed, we didn't see unequivocal high CO population. This is what our screener has started, and you can appreciate that there are some hyperchromasia of these superficial cells, but the size of the cell just only slightly enlarged, and there is no prominent coarse chromatin pattern. So it is very, very borderline, like a cell for a typical squamous cell. It's very borderline. So in this situation, after we screen for the entire smear, I think it is okay that we call it negative. But one thing we have to pay attention, and I frequently tell our screener that in this specimen, we didn't see any endocervical component. You have to write no endocervical component. Yeah. Otherwise, there would be a little bit like the clinician will feel very strange that why there's a high CO but there's no like a negative in the pap smear because there's no T-zone element, there's no endocervical component. So you have to write no endocervical component. So for this case, I think negative is okay, but you have to address that there is no endocervical component in the initial report. Okay, so everybody need to pay attention. If there is no endocervical component, you have to make a note in your report. So apparently, in this situation, the patient, the T zone of the patient's cervix is actually retracted in a higher level. So when you do a pap smear, it's not easy to get the area. And when you do even colposcopy, it is not easy. It is not until the cone biopsy you get a very like a deep inner inside T-zone to show there is a high CO lesion. Okay, so here I think the screener do a good job, but still you need to make a note that there is no endocervical component. So I think these couple weeks, I write a lot of check, no endocervical component check, no endocervical component in the report that you give me for the double check. So you have to remember if there is no endocervical component, you have to make a note in your report, okay? Okay, that's it. Thank you.